Welcome to the Lunch Symposium, the Clinical Conundrum, when cell-free DNA and biopsy don't agree. This has been sponsored by Natera, and on behalf of AST, I'd like to thank Natera for their continued support of the CIOT meeting. If you didn't have your badge scanned at the door, please raise your hand. Oh, there you are, and Natera staff will quickly scan your badge, so keep your hand raised. Oh, then you are with the staff. That's great. We have a great lineup of speakers for today's session. We have Dr. Dr. Kazi, from Providence Transplant Center, and then we have Dr. Gaurav Gupta from Virginia Commonwealth University Health, and they're already at the stage, so we'll let you get started. Thank you.
Thank you so much. Well, hello everyone. I'm Dr. Phil Gauthier, Senior Medical Director at Natera and a transplant nephrologist. I'm also a Clinical Assistant Professor of Medicine at University of Colorado Anschutz. Welcome to our symposium, When Cell-Free DNA and Biopsy Don't Agree, a Clinical Conundrum. But more importantly, welcome to CIOT, welcome to Scottsdale, welcome to warmth and sunshine. Yes. All right, so we have two great speakers. Do we have oh yes, we do have a clicker. So we have two great speakers today. I'm very excited to have these two great people up here with me today. So we have Dr. Yasir Kazi. Dr. Kazi is Medical Director of the Kidney and Pancreas Transplant Program at Providence St. Joseph Hospital, Orange County, California. He's also an Associate Professor of Clinical Medicine at the Keck School of Medicine in the section of nephrology. He will be discussing Prospera as an early indicator of rejection, presenting data from our published ProActive trial, and he will also be presenting some case examples from his clinical practice. Next, we have Dr. Gaurav Gupta, who is Professor of Medicine and Surgery, as well as Chief of Nephrology and the Co-Medical Director of Kidney and Pancreas Transplantation at Virginia Commonwealth University Health. But first, let me start with setting the stage for what we'll be discussing today. I guess you could call me the warm-up band. So this is a slide from a nice review article on cell-free DNA that was published in 2022. And on the left, it presents the AUC of cell-free DNA to detect rejection across a variety of studies using cell-free DNA assays from different companies in different settings. And as you can see, overall, the performance for cell-free DNA to detect rejection is quite good. On the right, you see a similar presentation for serum creatinine, and you can see it's not as good, and perhaps more significantly, even in the best performing study, the confidence interval touches the 0.5 line. So it's fair to say that in none of these 6 studies was serum creatinine statistically significantly associated with rejection. Now here's the performance of Prospera from 3 different studies, 3 very different cohorts. Our original clinical validation on the left, which was a single center study. A second validation in the middle, which was 25 US and international sites using molecular microscope as truth. And then finally, the Bromberg proactive study, which we'll be presenting in more detail today, which was 40 US sites. And what's remarkable is we got very similar performance in terms of AUC across the board, 0.87, 0.88, and 0.88 again. Positive predictive value for our test is about 52%, 68%, and 33%. And I think most clinicians would agree that cell-free DNA is a very sensitive test, but it's less specific. And that while you're unlikely to get false negatives, you may get some false positives. Well, it turns out there's a lot more complexity to that story than we initially appreciated. For example, here's data from a paper that we published in late 2023 with Phil Halloran and the Alberta group using molecular microscope. And what we showed in that paper is that amongst 134 patients without rejection, we nevertheless saw a strong correlation between cell-free DNA levels and ABMR score. So in other words, even in patients without rejection, they were patients with higher ABMR scores that didn't meet the rejection threshold, and these patients tended to have higher donor-derived cell-free DNA. And some of the conclusions from this paper, which survived peer review, are there on the slide. I won't read through all of them, luckily. But the main one I want to point out is this concept of sub-threshold rejection. And it turns out these changes are real and have a clinical impact. So this is a completely separate study from the Intercomex cohort that was published several years ago. And on the left, he looked at the correlation between ABMR score and all 1,679 patients. And not surprisingly, patients with higher ABMR scores had worse graft survival. But then on the right, he did the same analysis for patients who did not actually have rejection. So these are all patients whose biopsies were read as no rejection. Nevertheless, he still saw a correlation between higher ABMR scores and worse graft survival. So it may be that some of these so-called false positive tests are actually picking up subthreshold rejection. And Dr. Kazi will develop this theme further and layer on additional levels of complexity when he discusses the proactive registry and also presents some of his cases. So his section will be focused on this concept of false positives. And then lastly, I want to point out that most people feel, and this is what's published, that donor-derived cell-free DNA is less sensitive for T-cell mediated rejection. People say, oh, it's great for ABMR, but not as good for TCMR. Well, it turns out that also may not be entirely true. And I will not say anything else about this, but Dr. Gupta's presentation will make a very nice case using his own original clinical data that cell-free DNA may be a lot better for TCMR than we initially thought. So that's enough from me. You're not here to see me. So I would like to now turn it over to Dr. Kazi. Yasser.
Thank you, Phil. Hope everybody is doing well. I know the New York Times article came out this morning, but I just want to tell everybody I'm so proud of us, everything we do. We have imperfections in our field, but we're constantly, always evolving, always trying to make it better. And to some extent, that's sort of like the theme that we have today. Timing is everything in transplantation. How quickly you get a transplant and how quickly you detect injury, how quickly you detect rejection is important. Because the conventional things that we had, serum creatinines, proteinuria, by the time that we realized there was damage happening, we had kind of lost on time. And I always, as a transplant nephrologist, and looking at how many nephrons are we losing and what can we do to detect injury early. So what if we had the ability of finding a biomarker that could predict a rejection storm that might be coming up in months to come. And basically, that's what I'm here to present. Oops, sorry, let me go back. Which was the proactive study, and I was part of the study. Like, how does the elevation of the donor-derived cell-free DNA correlate before the biopsy? This is the sort of consort diagram. As you can see, a very large study of 4,667 patients, and these were patients that were enrolled prior to December 1, 2022. Of those, about the folks, 1,631 had completed about 18 months of follow-up post-transplant, and there was a requirement of having followed these people for about 18 months. Of those, about 1,600 met up the complete inclusion criteria. And during that time, about 634 biopsies were done. And what was important is you had to have at least one donor-derived cell-free DNA during that time, which resulted in about 424 patients. And these are the ones that had a simultaneous biopsy done. And as you can see, the breakdown, there were about 26 ABMRs, 62 TCMRs, and then the other group that basically we couldn't find anything is there was no rejection. And those were about 336 patients. So when you look at the slide on the left, when you see the donor-derived cell-free DNA, and the red dotted line is the timeline when the biopsy actually happened. And the preceding months, as you can see, for the donor-derived cell-free DNA for the ABMR, it was statistically significant for 5 months prior to it. So you could see that 5 months prior, there was an elevated donor-derived cell-free DNA. And this was the same as for TCMR, but up to 2 months before. And you can see the separation between the green ones, which are no rejection, the light blue ones, which are the TCMR, and the ABMR, which is the lighter blue. You can see the separation as opposed to the serum creatinines, which are all lumped together. They're all landing in together, not giving us the ability to kind of like have that correlation. So it's important to understand, like these are very significant, all those 5 months that you can see highlighted in the yellow timelines, where the elevation was pretty significant. And again, these are folks that had very normal serum creatinines, as you can see on the left. And then more importantly for me, as we've gotten to realize over the last 5-6 years of using it, that even the ones that may have no biopsy findings of rejection, but persistent elevation, it does result in an impact on the GFR. And as you can see over here, the red curve, which is basically non-rejecting people, but persistently elevated cell-free DNAs. At the bottom, you see 1 having an abnormal or 2 having an abnormal. The GFRs do tend to have an impact on it. And for me, as a clinician, this is something that I'm striving to look for. And some of the cases that I will present on how it is important to actually be able to try and identify what might be happening in the allograft during these times, because eventually, longitudinally, as you follow them, more and more studies are sort of suggesting this, that you may have an impact on the GFR, as was also demonstrated in this cohort. So what happens if you have an initial biopsy that was a non-rejection? So during this study, there were 4 patients whose initial biopsy basically had a non-rejection biopsy, but when followed, did eventually result in a rejection. So there's a discord between a biopsy, which basically had an elevated cell-free DNA, as you can see in 3 out of the 4 ones, which had to be about 1%. And then subsequently, they ended up having a rejection. And so it is important to not just like label it as an abnormal. I just had this discussion with Dr. Singh a little while ago about even these abnormal ones, you need to follow them longitudinally. And in this case, it was subsequently a rejection episode that basically resulted in the subsequent finding. I'm going to present my patient who basically, I'm going to present 2 patients. This was a 72-year-old woman that I had seen, been on dialysis for about 3 years, received a kidney transplant in 2016 at another center after being on dialysis for 9 years at that time. But eventually the transplant only lasted about 3 years. And apparently the donor was fairly young, but the creatinines had never gotten better than 2 milligrams per deciliter. So she eventually got a transplant in August of 2023. She was 100% PRA from the previous transplant. And it was a 32-year-old donor, a 0 mismatch. The cold ischemia time was about 30 hours. The admit creatinine on the donor was 0.93, but one of those AKI kidneys where the creatinine had gone up to 4.3 was on CRRT. The biopsy at the time of the donor biopsy had shown the minimum sclerosis of about 6%. Overall, a good biopsy. It was induced with thymoglobulin, and the cross-match was completely negative. These are her creatinines and the tacrolimus levels, and as you can see, the blue, I don't know if it projects well, but she has really had excellent kidney function running around from about 0.8 to 1.2, 1.3, and fairly good tacrolimus levels. But when we started monitoring her Prosperas, as you can see, after the initial one, she had an elevated one in January, came down, and then went back up in March of 2024, at which point she underwent a biopsy. And again, this was with normal kidney function, and the biopsy came back positive for a borderline change for cell-mediated rejection. But then there was also this mesangial injury with IgM deposits. There were these linear IgG staining, so it raised the question of, is there like an anti-GBM disease going on? Was this a missed Alport? So she was tested for all those things, genetic testing, and her creatinines have been stable. So we just continued to monitor her, and yet again her cell-free DNA started to climb again, and at what point she was rebiopsied, and And the second biopsy, again, continued to show some microvascular inflammation. And during that time, she did get some pulse of, after the first biopsy, she was pulsed a bit, and her maintenance immunosuppression was adjusted. The TAC levels were increased. But despite that, there continued to be microvascular inflammation. C4Ds were negative, and that mesangial injury continued to pop up. Like there were IgM deposits, there were still these linear IgG deposits, and obviously, there was like a suggestion to correlate for non-HLA autoantibodies. And so these are things that are now sort of resulting in, at least in our clinical practice, to kind of like identify where the cell-free DNA might be coming from. What is the reason? So we sent out, obviously we always check for HLA antibodies. There never were any HLA antibodies. So we use Dr. Danovich's UCLA lab for all our non-HLA testing. So we did the MICA, which was negative, and AT1R, that was 1 to 6 dilutions. The endothelial crossmatch was slightly positive, but as I've started to realize, when we initially see people for end-stage renal disease, we do lupus workup and all that. And she had this episode where she had a sinusitis, so we sent out some ANCA tests, and they were like, very significantly positive. So we didn't know whether she had ANCA as her original disease. It might have had some consequences on that. She had, going back, it did lead us on to some suggestions she might have had some other features of ANCA vasculitis. So she now sees this in the rheumatologist note, and she's now being considered for rituximab therapy. Again, to a point like we basically were led to this path by like a persistent elevation, and while they weren't clear-cut, just cellular or antibody-mediated rejections, there was this injury that was uncovered as a result of persistent elevations in the cell-free DNA. And there's obviously the potential of missing all these etiopathogenesis that might be happening in the allograft, which can impact the GFRs, as I've shown you, persistently elevated prosperas, even in folks who had no rejection on the biopsy, does have an impact on the GFR. So it's sort of become our routine now, if we can't find an etiology, to screen out for other potential antibodies, including ANCA, ANA, anti-GBM, in trying to investigate the allograft injury. The second patient that I want to present is a 53-year-old male who basically was referred over to me, and I saw him in June of 2023. And this was basically just a long-term follow-up. The nephrologist, he had moved into the area, and he wanted me to just kind of do a little transplant workup. This was around the time, this is my note cut and pasted, this is around the time the Moedex confusion was happening, and even though this person had excellent kidney function, I just sent out a Prospera, and even though his creatinine was 0.8 and it had gone up to 1, I had to kind of make a cause. At that time, we were putting the language of why we were doing stuff. But to just give you guys an idea, this is how his creatinines have been, about 0.8, 1.5, and as a reminder, this guy's been transplanted 5-6 years ago from when I'm seeing him, and he is I have excellent kidney function. And this is how the Prospera comes back as. It comes back at 4%, and it took me a long time to the guy feels like he's perfectly fine. He's seeing me for the first time. I'm trying to make a case for doing a biopsy. It took us a while getting him to do a biopsy, which eventually was a pretty advanced cell-mediated vascular rejection, 2A, had a component of acute on chronic antibody-mediated rejection. It was C4D positive, which was a bit surprising. Here I'm seeing a guy who's walking around with a perfectly normal kidney function, and he has this brewing up, which is kind of so far advanced that he's having a hard time actually comprehending that this is happening, because again, he wasn't transplanted with us, he doesn't know me. And again, I showed you guys the previous slide. I think it kind of came out a little bit sooner, but these are his trends, and as you can see, the most recent one, just a couple weeks ago, has shot back up again. And he's been getting, IVIG, and he's basically been sort of managed appropriately in terms of the rejection. But he does have a donor-specific antibody. The challenge that we have. But again, brings sort of the important point that I always try to make. As a transplant nephrologist, we get, we get like 1 million nephrons that we get to play with. How many nephrons need to die before that creatinine goes from 0.8 to 1 to 1.2? And we've relied on serum creatinine for the longest time, and I don't think I would put Bob Dylan over here, but thanks to Timothy Chalamet, I can kind of like put up I can put this up, like how many nephrons do we have to lose before we realize that the creatinine has actually gone up? And I think we're at this very important time where we're realizing that we have the ability to detect rejection and beyond that, injury fairly early on, and it's on us to then strive to find out what we think might be happening inside the allograft. I think that's my last slide, and Phil?
Thank you so much, Dr. Kazi, for that great talk. And we'll take questions at the end, but just to summarize, if you see a positive Prospera and a contemporaneous biopsy does not show rejection, that's not necessarily a false positive, because some of those patients will go on to have rejection or another clinical complication at subsequent time points. So now I'd like to bring up Dr. Gupta to address the other side of the coin, that is false negatives for TCMR. Gaurav.
Thank you, and good afternoon, everybody. Shout out to Yasser for taking that kidney at sequence number 2, for those who know what I'm talking about. So tell me how to do this. What am I doing?
So this button right there.
Okay, thank you. Well, so for the next half an hour, what I'm going to try to do is to talk about this intersection of donor-derived cell-free DNA, or cfDNA for short, and T-cell-mediated rejection. As Phil pointed out, we've been discussing for many years that cell-free DNA is non-sensitive enough for TCMR. And what I would like to do is to present evidence to convince you that at least some of those cases are actually not false negatives, but rather probably true positives in terms of ruling out rejection. So these are my disclosures. So I'll start out with talking about how do we standardize a new test. And again, for those who've heard me give this talk before, ultimately when we look at a diagnostic gold standard, the gold standard has to be perfect to be able to calibrate a new test to the old test. And this is data which has been presented across many forums over the years. What it tries to do is to look at the different BAMF scores of inflammation, tubulitis, vasculitis, et cetera, on the left. And it tries to examine the agreement between a number of pathologists for these different scores. And what you see here is that the agreement between pathologists based upon a kappa score, which is graded as 0.2 being very poor and below 0.6 being moderate, is pretty moderately poor overall. So essentially, the point is that the agreement between pathologists for the scores that we use to diagnose rejection, primarily TCMR, are not perfect. Now, you could argue that this data is old and maybe we've learned a lot since then. And to that, I present you the slide on the right, where this is new data now. This is a BAMF-sponsored work group which looked at donor biopsies, and it looked at agreement between pathologists for donor biopsies. Now, on this, it's still pretty disappointing that the agreement remains poor for something as simple as number of glomeruli. So even that count remains disagreed upon between pathologists. And then you march it down across various different findings, and you find that we have a problem on our hands in terms of agreement between pathologists. So the question may be that maybe the issue is inter-observer variation. Let's look at that and dive into it a little bit more. This is a study from Columbia, which again looked at donor biopsies, and the same kidney was biopsied twice, in many cases pre and post. So it was biopsied at the donor center, then again at Columbia, or it was a post-perfusion biopsy. And even in this study where the same pathologist read the biopsy, both of them, there's still agreement which doesn't hit above 60%. So the problem here goes beyond the fact that there's variation. The problem is that kidney pathology can be focal. So the issue with using histopathology is that if you have focal findings of inflammation, how do you actually get to a state where you can look at the whole kidney in terms of the tissue? And this is one of the solutions amongst many. So the molecular microscope, or MMDX for short, looks at microarrays, so the whole tissue gene expression transcriptome of the kidney. And it tries to use machine learning way back when, before it was cool, to try to provide these scores, which can be then divided into rejection, TCMR, ABMR, et cetera. So the concept here is that if you have gene expression, one, you take out some variation, and second, hopefully, gene expression changes for different pathologies will be uniform across the kidney as opposed to focal in terms of the tissue histopathology. So this is one of the studies from that data set. So what does discrepancy between traditional histopathology and MMDX looks like? And I want to focus only on TCMR for this talk. And what you see is that there is around 15% of cases where there's TCMR on MMDX, but not on histology, and around 10% where vice versa is true. So point is that around 10% of the time, there is no rejection on MMDX, but there is inflammation and TCMR on histology. And this is the question, are these real cases or not? And that's what I'll show you later in this presentation. So is this only true for MMDX? Do we have external validity for this data? This is a large study from Paris, where they combined data from Paris, from Wisconsin, as well as the Eurotrain trials. And they tried to actually apply known BAMF rules to create an automated BAMF system. So essentially, as opposed to depending upon subjective criteria by pathology, as well as using I1, I2, so on, as discrete variables, they tried to put this into a machine learning system to see whether that changed the diagnosis for these biopsies. And what you see here is this Sankey diagram, which I want to again focus on only TCMR, which you see here highlighted in red. So what you see is that on prior assessment based upon the pathologist, acute TCMR was present in around 13% of the cases, but was reclassified using this automated system down to 6%. And I'll hold that 6% in your mind, which I'll show you again. The same is true for borderline rejection, which was around 28% with the old system, and dropped down again to nearly half with the automated system. So even using BAMF criteria, there is a change in TCMR diagnosis in terms of using newer methods of classification. So with that background, now we move on to the next step, which is what I was describing earlier on. Since we've established that we do need to have better histopathologic classifications, can we try to recalibrate cell-free DNA with a newer diagnostic standard? And this is what we try to do in the study, where we combined cell-free DNA with histopathology and MMDX to try to understand what the signals were in their association. So this is a single center study. You can see it's a fairly large single center cohort of 200 some biopsies. The only other point to present on this slide is that nearly half of the biopsies were done for indications like acute kidney injury or proteinuria or DGF, and the remainder were done for surveillance. So kind of a 50-50 cohort, which helps the case of surveillance biopsies being also represented in this cohort for cell-free DNA measurement, which is a fairly sensitive biomarker. So once again, I'm going to focus primarily on TCMR. What you see in the blue, in the red rectangle here is any rejection first. What you see is that compared to histology, the classification using MMDX does increase the number of rejections from around 38 to 44%. When you look at TCMR, you will notice that it goes from 13 to 6%, very similar to the BAMF automation system paper, where the numbers were very similar in their entire cohort also. So TCMRs went down with MMDX compared to traditional histopathology. When you kind of go down further into BAMF grading of borderline 1A and 1B, you start seeing that cell-free DNA show a pattern where cell-free DNA is low for borderline, slightly higher for 1A, and then even higher for 1B. Now, you could argue this is This is kind of obvious because you have bursting rejection, but I would argue that maybe these are normal biopsies without rejection. And I'll show you data to try to convince you of that. So in terms of disagreements in our cohort, around 20% of rejection samples in histopathology were reclassified as non-rejection by MMDX, and around the same number had the opposite, where MMDX was positive for rejection and histopathology was showing no rejection. Once again, focusing on TCMR only, what you see is that some 1As, some 1Bs, some borderlines, and some mix were all reclassified as no rejection using MMDX. What you see is that most of these reclassifications occurred in 1A or borderline rejections, suggesting that mild TCMR is the primary focus of this debate. So what about the distribution of cell-free DNA scores? On the left, you have histology. And what you see here is that borderline TCMR has the lowest scores of all for cell-free DNA. The same is true for 1A TCMR to some degree, but not entirely so. When you look on the right, you have MMDX diagnosis now, where again you see that TCMR has somewhat lower scores than the others, similar to previous studies. You also see that there are certainly some cases of TCMR which are low with cell-free DNA. So the answer remains that there is certainly a portion of TCMR where cell-free DNA does not go up. So the sensitivity in this analysis of our cohort for ruling out TCMR was 92% for a cutoff of 0.21%. So the same has again been confirmed with Trifecta, which is a large multi-center cohort from Canada, from USA, and Europe. And what they tried to do was similar to what I presented, where they had simultaneous biopsy, histology, MMDX, DSA, and cell-free DNA. And once again, the trends are similar to what I showed you before, where TCMR does have lower cell-free DNA compared to the other rejection diagnoses, but again, the message here changes in the next couple slides. So what these authors then did was they combined fractional cell-free DNA, which I'll talk about in a moment. As we all know, cell-free DNA is mostly reported as a fraction, meaning the denominator is donor DNA, the denominator is all cell DNA. And this fractional measurement is the most commonly reported one, but in this case, they combined the fraction with the quantity, absolute cell-free DNA from the donor, and this combination resulted in a better AUC for rejection prediction compared to either of them alone. In terms of TCMR only, what you see in the bottom is for histopathologic diagnosis for TCMR, the sensitivity was pretty low for cell-free DNA in combination of the fraction and the absolute quantity. But for MMDX, it was pretty perfect, but it's probably overtraining, but nevertheless, the point remains that there is a significant benefit in terms of trying to calibrate cell-free DNA with the molecular standard as opposed to the histopathologic standard in the study. So again, to take a step back in terms of the absolute quantities which I mentioned, so as I mentioned, the way to present cell-free DNA data is numerator being donor DNA, and the denominator being a combination of donor DNA and recipient cell-free DNA. Now, what we know about this concept is that in conditions like inflammation, sepsis, and things like that, the denominator may change and go up because there's more cell death happening. And in that case, since the fractional proportion depends upon the denominator being the same, the fraction may falsely go down, and that may not present the complete picture sometimes. And this is one study which talks about this concept. So what you see here is at the top, this is a study from Germany where they showed that there's total cell-free DNA over time post-transplant. It goes down slowly over many years of transplant. While donor-derived cell-free DNA, copy numbers is trending up a little bit. And what happens is visible in this slide, where you see that since the total cell-free DNA in the blood is going down, and the copy numbers are slightly up or unchanged, but that results in the fraction going up a lot more. And the authors theorize that the reason for that is because these patients who are being on mycophenolate for years, their white cells go down over time. And white cells are the primary source of cell-free DNA in the blood. So that's why as the total cell-free DNA goes down, the fractional measurements go up. And that's one of the benefits of presenting both of these data points together, which is copies as well as the fractions. So with that, let's move on to the next step, which is what we did in our center, where we wanted to now look at, we assume that some proportion of TCMR is false positive by histology. Can we actually apply that to management strategies? So in this publication, we tried to divide patients into 3 groups. We had a prospective protocol where we agreed as a center to not treat patients who did not have severe AKI till the MMDX report came back. So we have 3 cohorts here. On the left, you have H plus M plus, which means the biopsy is positive for TCMR by histology and by MMDX, and they got treated. In the middle, you have H plus M minus, which means histology positive but MMDX negative. They did not get treated with steroids or thymoglobulin. And then you have a control population of contemporary biopsies where there was no rejection by either technique, and of course, they did not get treated. This is a publication. The primary author is my colleague who's in the audience, Dr. Kumar. So what we did here was to try to then look at the outcomes of these patients. Demographics-wise, what you see here is a couple differences between these cohorts. More patients in H plus M minus, meaning MMDX negative H plus biopsies, and more patients without rejection had surveillance biopsies compared to those with rejection on both technologies, which kind of makes sense because this is not a randomized trial. This is a prospective protocol. And the other difference is in the kidney function. Again, patients with rejection by both technologies had worse kidney function at baseline compared to those in the other 2 groups. So this is, these are the scores that we found for these 2 groups, these 3 groups. H plus M minus is the blue bar. H plus M plus, that is, again, rejection by both technologies in the red bars, and the green bars are the controls without rejection. So what you see on the left are the BAMF scores of I, T, V, microvascular inflammation as G and PTC, and IFTA based upon CI and CT. So what you see here is that there is the INT on histopathology is significant in H plus M minus, but it is more so in H plus M plus. And it is higher than H minus M minus, meaning there is inflammation as well as tubulitis in H plus M minus group by histopathology. But when you look at the molecular scores on the right, you can see that the TCMR scores on the molecules are very low for H plus M minus and comparable to the non-rejection group, which is not true for the rejection group for the dual technology. So this to us suggests that there is no alloimmune cognate allorecognition in these biopsies, and I'll talk about this concept in the next few slides. When we dig deeper into this H plus M minus cohort and try to divide that into BAMF grading by borderline 1A, 1B, once again, on the left, you see the INT is going up rapidly based upon the severity of rejection, based upon BAMF grading. But when you look at TCMR scores by molecules, there is no difference between the 3 biopsy groups. What is changing, though, is AKI. So molecular acute kidney injury is increasing by BAMF grading. And this is a concept which I'll return to at the end of this talk. So what about kidney function numbers for these 3 cohorts? So what you again have in the red bar is H plus M plus. They start low, they get better with therapy, thymo or steroids, and then they kind of slowly drift down again because of events that happen in the future, which I'll show in the next slide. The second is H plus M minus. They start lowish, but not that low, and they improve over time without any specific therapy for rejection, indicating possibly resolution of AKI for whatever reason that happened. And then the last group is the control group, where there was no rejection, but they did get biopsies, and once again, as expected, they improve over time because of resolution of AKI, and they stay stable for the period of follow-up in the study. What about graft survival? This is pretty dramatic. You can see that H plus M minus and the controls have equivalent graft survival compared to H plus M plus, where graft survival is much worse, which is kind of expected because they have rejection, which is true TCMR. Now, one of the comments that was made about this publication was that, well, borderline is a different grade of rejection, and therefore you should not include them in our analysis. So we did that. We did only 1A and higher for the H plus M minus group versus 1A and higher for H plus M plus. And what you see is that this difference remains significantly different. So patients with molecular absence of rejection did much better compared to patients with molecular presence of rejection. Other outcomes, the colors have changed, but the yellow bar is H plus M plus, again, rejection on molecules, and H plus M minus, meaning no rejection on molecules. So what you see are other endpoints which are of relevance to us clinically, which is recurrent rejection. So there was a lot more recurrent rejection in the molecular rejection group in the future, moving from the index biopsy. A lot more DSA detected after that event in the future, despite the fact that they had less DSA at the time of biopsy compared to the molecular negative group. So essentially, the point is that H plus M minus group did pretty well. Stable GFR, absence of recurrent rejection, absence of DSA in the majority of the group. To us, that suggests that this is probably not true TCMR in a majority of these cases. Now, we've taken this to the next level, which is where this talk today comes in, cell-free DNA. A subset of these patients had serial cell-free DNA data. So in that, now we have 26 patients with dual rejection, 16 with molecular negative, and 100 patients or so with no rejection by both methods. So what you see is the data for those patients. Patients with molecular rejection, H plus M plus, start out high with cell-free DNA, which is expected. They have true rejection. They improve with therapy, and then over time they start inching up again, probably because of recurrent rejection or probably because of AMR as their DSAs are going up. Compare that to the other two groups where the cell-free DNA remains low consistently throughout the follow-up time. So once again, the suggestion here is that this is probably not true rejection, and cell-free DNA may help us differentiate these cases from each other. So coming back to the concept of AKI, so I think at this point we can agree that cell-free DNA is not a rejection-specific biomarker, but rather an injury biomarker. So the question is, why is it going up to some degree in these cases where there is histologic TCMR but not molecular TCMR? And I point out this AKI score business that I showed you the last few slides, where with worsening TCMR and histology, AKI scores are going up. Now, we think that the theory behind this is the fact that injured kidney tissue recruits local and circulating T cells. And this is a response to wounding as opposed to T cell beta rejection, which is because of allorecognition. Now, we think that this is what's happening with the histopathologic findings on tissue biopsies, where you have lymphocytes, but we would argue that that's probably not rejection, but rather simply a response to wounding. And there's some data which suggests and supports this from our study as well as Trifecta. So what you see here is patients with rejection, which are in the red circles, and no rejection, which are in the red squares. So what you see here is that a majority of patients without rejection are below this threshold of 1%, but there's a positive correlation between cell-free DNA going up and these non-rejection biopsies in terms of molecular acute kidney injury. So we believe that cell-free DNA is going up in tandem with molecular AKI, although it doesn't go above 1%, because in most cases that is severe injury, probably because of rejection or other pathologies like vasculitis, which Yasser presented. So ultimately, the point is that this is a sensitive injury biomarker, and in most cases, the levels, the higher they are, the more specific it becomes for rejection. This is similar to what trifecta showed. So what you see here in the highlighted areas that I show you is that cell-free DNA seems to, again, correlate nicely with molecular AKI in this larger cohort, similar to ours, irrespective of rejection or no rejection. So to conclude my presentation, donor-derived cell-free DNA is an ultra-sensitive injury biomarker of kidney transplantation as opposed to rejection-specific biomarker. And therefore, it does go up slightly in some cases of seemingly positive TCMR, but rather they are not TCMR cases. Our studies suggest that early TCMR can be risk stratified with the inclusion of cell-free DNA, where levels which are high argue in favor of TCMR, levels which are low argue against TCMR diagnoses. And then finally, our study, which incorporated MMDX into TCMR management for early cases, mostly borderline and 1A, where histology was positive but MMDX were negative and cell-free DNA was low, suggests that acceptable outcomes in the intermediate term, even in the absence of intensification immunosuppression. And with that, I'll end. I'll thank a lot of my collaborators in the KITE study group that we have at VCU. Thank you for your attention.
So yeah, I don't know about you, but that paper just blows me away. So just to summarize, it seems that many cases of borderline and milder TCMR do just as well, at least on the intermediate scale, without treatment, and that you can distinguish these as compared to patients without rejection, and that you can distinguish these cases from those that do need treatment using molecular biomarkers such as donor-derived cell-free DNA and molecular microscopes. So I think this could really represent a paradigm shift. Another thing I noticed, Gaurav, is it looks like the DSAs weren't able to distinguish because the patients that had milder rejections and negative cell-free DNA, negative molecular microscope, their DSA was basically the same. So DSA can't distinguish either. So you're going to have to rely on donor-derived cell-free DNA and or molecular microscope to know which patients could potentially avoid, fairly debilitating anti-rejection treatment. So with that, we're very happy to take questions. It looks like we actually are on time, so we do have a full 20 minutes for questions. So if anyone would like to ask any questions, just come up to one of the mics, and one of our experts will be able to answer your questions. Thank you.
So I'll make one more point, Phil, about the DSA story. So we didn't talk about AMR today, but we know from multiple published studies now that half of late antibody rejection, up to 50%, is DSA negative, which is actually not true for cell-free DNA. So our position at our center, backed by many studies at this point, is that cell-free DNA is a more sensitive biomarker even for antibody rejection as opposed to just for TCMR, compared to DSA. So DSA being present is useful, but absence of DSA should not convince the clinician that there is no AMR present.
Just to clarify things, I'm not exactly sure, but when cell-free DNA is activated and yet histologically you don't see rejection, maybe it's signs of AKI, et cetera, how do we know what came in first, the chicken or the egg? In other words, injury recruiting certain immune cells, which then triggers the subsequent rejection.
So you're right. I think that is a primary question which we don't have the answer to. But ultimately, the proof is going to be in terms of a controlled trial where you do not treat patients with molecular quiescence in terms of rejection versus treating patients who don't have that. So there's no other way to prove this hypothesis because our study is not a controlled study, so we cannot prove that. But
I mean, CMV reperfusion injury opens up certain processes that trigger antigen presentation and ultimately rejection. So I don't know. I'm very clear as to what's the process yet.
I think at our center, it's basically just an indicator of somebody that is now in a high-risk situation. Like, we've always classified patients as high-risk patients we're trying to now identify high-risk situations. So whatever the AKI might have been there from, to your point, is going to potentially trigger off alloimmune responses, especially in the context of their immunosuppression were reduced a couple weeks ago, months ago for a UTI or something. So I think we're trying, but there's no clear-cut answer. You can't, like Gaurav said, the only way would be for me not to have treated these people that had perfectly normal creatinines and, and their cell-free DNAs were elevated and see what would eventually happen.
So what's the frequency of cell-free DNA if your creatinine is stable? You only see the patient every 6 weeks, 2 months. You do one every visit?
Oh, no, of course not. It's sort of like, to some extent, at least at our center, it's based on their immunological risks, or like if they had a marginal kidney, like we accepted a kidney that we're not trying to maximize ACE inhibitors on and their creatinine's gone up, it's drifted. So we might do, it's sort of individualized to the patient. Not everybody gets like a frequent, set protocol.
Yeah, and I can add a little bit to that, because this is something that I just find fascinating is, cell-free DNA is part of the immune response. So cell-free DNA can be recognized by TLR9 receptors. Neutrophils actually use cell-free DNA to form these neutrophil extracellular traps as part of the response to pathogens. In mice, it's been studied as part of the obesity-associated metabolic syndrome. Specifically, these mice have high cell-free DNA levels, and then both TLR9 knockout mice and mice given cell-free DNA blocking oligonucleotides, the response is completely abrogated, so it's just gone. Now, what we don't understand is there an aspect of non-self cell-free DNA that could be more immunogenic? And if so, what specifically is being recognized? Is it the non-self histones or something else? So I think there's still a lot of work to be done there, but it's possible that we're seeing a synergy between cellular injury, which results in release of donor-derived cell-free DNA, which then somehow ramps up the recipient's immune response. And that could explain some of the lag that we see with the elevation in cell-free DNA and then subsequent rejection. But there's a lot more work to be done there.
Yeah, I'm glad you bring neutrophils, because reperfusion injury is associated with recruitment of neutrophils. And neutrophils are actually been recently demonstrated to bypass macrophages and directly present antigen to B cells and to T cells. So there are players that are being ignored, but maybe we should study them better.
Yes, thank you.
Hey, Gaurav. As always, amazing work out of VCU. Did you look at sort of the BK infections in the patients that you were talking about? Because it does seem to me that it's, beyond the, thymos is not a pleasant thing. Thymos bad because of BK and that sort of stuff, and with your data, do you think we can reduce the incidence of BK nephropathy by avoiding intensification, and have you seen evidence of it yet?
Thank you, Dave. So in terms of the data for infections for this large cohort, we don't have it in terms of high quality. What we did see was the patients in H+M+ who got treated, there was a significant number of infections in those patients. Not BK, one had osteomyelitis, several had sepsis, 2 died because of infectious complications. So I think we know that the therapies that we offer these patients have consequences. What we don't have for you right now is in terms of the question that you asked, but is what happens to, across the group, all of these patients for infectious complications. The molecular picture of BK is also pretty interesting. It's in terms of the intersection of BK with cell-free DNA, that is also a very interesting question to understand, because what we see in those patients is that typically in the early phase of just BK nephritis, cell-free DNA stays low. But as you keep reducing immunosuppression, as the patient moves towards rejection, cell-free DNA starts going up. So typically when we start seeing high cell-free DNAs in BK, we start worrying about rejection in those patients, mostly antibody rejection.